Acknowledge that this land on which the Fields Institute operates, for thousands of years, it's been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we're grateful to have the opportunity to work on this land. And I will turn it over to Zhen Heng, who will introduce our speaker today.
Thank you, Ben, and thank you, Professor Cowling. On behalf of the Fields Institute and its director, Kumamuti, who is also the PI of the Mathematical Public Health Network, like to really say it's really a privilege and a pleasure to have Ben, Professor Cowling, with us to start off the colloquium series of Mathematical Public Health and Fields Institute for 2023. And many of us, including myself, have been closely following Ben and his collaborators' work on mathematical epidemiology in general, but COVID-19 modeling and analysis in particular over the last few years. And it's a very challenging time, but it's also time to see how somebody's work has influenced the shaping of the scientific mind and some of the public health interventions. So Ben, Professor Cowling is currently chair professor of the epidemiology and head of the division of epidemiology and biostatistics in the School of Public Health at the University of Hong Kong. And he is co-director co-director of the WHO Collaborative Center for Infectious Disease Epidemiology and Control. And in addition to all those important scientific role, he is also on the editorial board and chief editing for many important journals in the field. And not to mention, and his significant role of tracking and modeling the COVID-19 in the last few years. So thank you again, Ben, for coming despite the time difference, and we're looking forward to presentation and discussions. Thank you, Ben. It's your time.
Thank you for the introduction. It's my pleasure to share some of my work with you today. I'll go back to the beginning of COVID first. And I can also tell you at the beginning, I guess all of you didn't know, I'm actually Canadian. I'm British, but I'm also dual nationality Canadian. And I was forced in 2020 to get a Canadian passport when I wanted to come to visit Canada on holiday. I applied for the ETA and was rejected because I'm supposed to get a passport as a Canadian citizen. So maybe I'll come and see you sometime and be able to use my Canadian passport for the first time to do that. I moved to Hong Kong in 2004 after the first SARS epidemic in Hong Kong, which was in 2003. Hong Kong is a small subtropical city on the south coast of China, very dense population, and it's been a gateway to China in the past. 20 years ago, when SARS-1 first emerged in Guangdong province, it spent about 3 months spreading in Guangdong province before one case made the journey to Hong Kong for an academic conference, if I remember correctly. And within a week, the virus had spread to Canada, to Toronto, and to other parts of the world through Hong Kong. So it was the gateway for SARS to get out. And the reason I went to Hong Kong 20 years ago was to be part of a new team. At that moment, we're just 3 of us, to work in preparation for a future SARS-2. And that was on our mind for many years. We worked on influenza in the meantime and other things. And then 20 years later, SARS-CoV-2 has finally come. And we feel like we were ready in Hong Kong to do some early work. I'm going to talk about a few different things. I'll try to go for about 45 minutes. Some of the early work that we did in the beginning of 2020, and then some issues specifically in Hong Kong about vaccinations, the impact and severity of Omicron, and then if I have time, some of my work on vaccines, which which I'm spending most of my time on at the moment. So in mid-January, my colleagues and I were keeping a close eye on the new cases of pneumonia reported in Wuhan. We were wondering what was going on. And we asked China CDC if there's anything we could do to help, and didn't hear much in mid-January. But later we did have the opportunity to collaborate with them on this analysis of the early transmission dynamics, where from the data on the first 425 cases, we were able to estimate the reproductive number of 2.2 and some other characteristics of the infections, and confirmed that really COVID was spreading and needed to be stopped if possible, or at least slowed down. And the paper we published in New England Journal of Medicine on 30th of January is by far my most highly cited paper. And that was written in a very short interval of time, I think over the weekend, basically from myself and colleagues and the colleagues in China CDC. One of the early things that we picked up through discussion with China CDC, and also there were some anecdotal reports at the time, was pre-symptomatic infectiousness. There was a report from a case in Germany in a business meeting that was, I think, may have been retracted or corrected maybe in January or February 2020. What we recognized is that there was quantitative data on the timing at which infections were occurring that allowed us to publish a paper in Nature Medicine on pre-symptomatic infectiousness actually being very common. And that was very controversial. I would say even now it is somewhat controversial that people might be infectious before their symptoms appear. Not everyone agrees that that's happening. Obviously in China, because the data that we used in this study was collected at a time when containment was underway, there's some reduction in the post-symptomatic infectiousness because of control measures, and that pushes the distribution to the left. But we were confident that there was a lot of pre-symptomatic transmission going on. And with this paper and some other work as well, we tried to alert the rest of the world that this was really happening at an important scale. We also worked, initially, this was published, I think, in mid-2020, but we started work quite early on how epidemiological distributions were changing over time. So we looked at a few different things, and I'll show another one in a moment. Serial intervals changed in China in the early part of that epidemic in Wuhan that was contained. And so we looked in the periods in the Wuhan epidemic in early 2020, before their peak, at the peak, and then after the peak. And there was clear evidence that serial intervals were shortening. And we attributed that to the effective containment, particularly later in contagiousness, later in disease. And we felt that was an interesting observation. Until then, I'd certainly imagined that serial interval distributions were fairly constant, hadn't really thought about it too much. But that stimulated me with an idea to look in lots of other places for changes in dynamics over time. Now, in Hong Kong and Singapore, and also in China, of course, there was a very different approach. Sorry, Canada's in the middle here, I didn't highlight. There was a very different approach chosen in Hong Kong, Singapore, China, and also Australia and New Zealand, where the idea that was implemented was to try as much as possible to keep COVID out of the community. In the early days, it wasn't clear whether that would be feasible, but in Hong Kong, I think the government decided to attempt to do that, and Singapore as well, and some other places. And the strategy had different names at the beginning, local elimination and so on. And later on in the pandemic, it's become called zero COVID, certainly in Asia. China particularly called it dynamic zero COVID through 2022, emphasizing that it's a dynamic strategy. It's not a single set of measures. There's actually two phases to this approach to local elimination. And I think it does reflect what happened in Hong Kong, what happened in Singapore, what happened in Australia and New Zealand, and mainland China, of course, in the first 18 months or so of the pandemic. So firstly, if or when there's an outbreak in the community, you have to rapidly control it. And that requires social distancing, perhaps, case finding, perhaps, other types of measures, certainly a lot of testing to stop outbreaks and get the number of cases down to zero. Not just slow down transmission, not just flatten the curve, but stop it. And then when there's a period of time with no cases in the community, the critical thing is the border control, stopping cases from coming into the community and transmitting infection in the community. So on-arrival quarantines are really important. And in Hong Kong, in Singapore, in China, in Australia, New Zealand, designated facilities were used for on-arrival quarantine. This was not quarantine at home. It was quarantine in hotels. In Australia, I think they used army camps or other facilities. In Singapore, they used old traditional style holiday camps. It was really important to minimize the opportunities for COVID to get into the community, because if you can stay at zero for longer, the domestic measures are not needed. You don't need masks, you don't need social distancing in the community because there's no cases in the community. The travel measures are essential. And I think where Australia found it was a little bit difficult in Melbourne, particularly, was getting to zero and being able to stay at zero. They spent a lot of time in the containment mode, not so much time in the zero mode. For Hong Kong, we did a really good job in keeping COVID out of the community for the first 2 years of the pandemic. We had a number of epidemics of the ancestral strain, the Wuhan strain of the virus in 2020, and then in early 2021, which we got under control each time. So in Hong Kong, the authorities took about 4 waves. The first one you can't even see, it's so small. It's a number of people bringing infection from mainland China into Hong Kong and causing a few small outbreaks in Hong Kong. The second wave is a little bit bigger in March and April of 2020. That was triggered by cases coming to Hong Kong from Europe, not from mainland China, because in mainland China, the cases had been mostly controlled by then. So we had infections coming in from Europe and North America. That was eventually controlled. And then we had another wave that was controlled, and then another 4th wave that was controlled. And then for the second half of 2021, we had very few local outbreaks or threats of local outbreaks. A lot of cases picked up in the on-arrival quarantine, but it was really a brilliant opportunity to get vaccine coverage up to a high level. And Singapore did that, got vaccine coverage to a very high level, and then transitioned away from the containment measures to maybe you could say mitigation measures, and then eventually living with the virus. In Hong Kong, the plan in the second half of 2021 was still very much to keep going with zero COVID indefinitely. No transition plan, no timeline to stop the travel restrictions, to stop the containment measures if outbreaks occurred. The plan, as announced, as described, was very much to keep going with zero COVID for the long term. And so I'll come later to what happened with vaccination uptake. But the first 2 years, we had just 12,000 confirmed cases with a lot of testing. And I have some serologic studies of people in Hong Kong, thousands of people providing blood samples at regular intervals in Hong Kong. And when we test those for antibodies, by the middle of 2021, there's less than 1% of people with evidence of infection. So we know there's really very few infections in the first 18 months. Later, that's a different story, but for the first 18 months, very few infections and a very small number only of deaths. One of the things we were able to do with the detailed data in Hong Kong is to look at super spreading dynamics. And so the left-hand side of this shows a number of clusters of cases that could be put together from contact tracing data, some sporadic cases as well. We know there's missing links because all the cases were linked with each other. There were only a handful of different strains of the virus according to sequence data. So we know there's missing links between them, but when we look at the degree of overdispersion, it's very substantial. And so on the right-hand side here is the offspring distribution. 70% of cases didn't transmit to anyone else, and 19% of cases we estimated were responsible for 80% of transmission events. So that is super spreading. And my postdoc Dylan Adam and I wrote an article in the New York Times saying that if we can stop super spreading, we can stop the pandemic. If we can stop the large outbreaks, particularly the right-hand side of this distribution. So if we can stop the super spreading, we can successfully control COVID. Our suggestions were things like don't allow large gatherings, and that would be a particularly effective NPI. So I think that was in April of 2020. So subsequently, we've looked at the possibility of super spreading changing over time. I said we've been looking at parameters changing over time. And what we find actually is in the second wave, the third wave, the fourth wave shown on the slide here, the reproductive number is above 1 each time during the epidemic. The dispersion parameter actually goes down, and the proportion responsible for 80% of transmission starts at about 20% and goes down as the epidemic proceeds and as we bring it under control. And so using the interpretation of K as a smaller value of K means more super spreading, more over dispersion, we actually have shown that Hong Kong's containment of these community epidemics was associated with more super spreading, not less. So we did stop the larger clusters, but what happened even to a greater extent, and the reason we think this has happened, is because we got more zeros. And so if I just go back to the previous slide, over dispersion is a description of the variance of this offspring distribution, where it's a heavily skewed distribution, but the variance comes not only from the right-hand tail, but also the zeros. And what we think has happened as the epidemics become under control with successful contact tracing and isolation and quarantine of contacts, and by the end of the fourth wave, quarantine of contacts going 2 steps out, as that continues, there's more and more terminal nodes of people who don't spread infection to anyone else. And so while K has decreased, the transmission has been brought under control. So I'm now thinking what would be another metric to use to explain this a little bit better, because what we want is less large outbreaks. But if we talk about super spreading and K, we have to think a little bit more carefully about maybe measuring it and interpreting changes in that. So this is still work in progress. By the middle of 2021, I think we recognized that COVID was becoming a little bit difficult to control. So this was the ancestral strain. It was not any variants at this point. It was still the original strain. And the fourth wave was only just brought under control by the universal masking that we've had until even now for 3 years. And then some moderate social distancing measures, a lot of testing, a lot of contact tracing and quarantine and so on. And part of the reason for that was fatigue with public health measures. So my team have been doing telephone surveys of the public in Hong Kong for on a weekly basis sometimes, or sometimes less frequently, for 3 years now. And so each of these data points is from a survey of either 500 people or 1,000 people, from random digit dialing. And the blue, so the purple is people saying they avoid social gatherings. The red is avoiding crowded places. And we see evidence of fatigue between the third wave in the middle and the fourth wave on the right-hand side, with people becoming a little bit tired with the containment measures. And in a paper in PNAS, in 2022, not 2020, sorry, in 2022, we showed that this fatigue contributed to more infections in the fourth wave, and also to the difficulty in getting that wave under control. So I'll come to vaccines in just a moment. There's one more thing to share with you about viral shedding, and before I get to that. There was an interesting paper in Science about how the change in characteristics of people that are tested during an epidemic can be used to make inferences about the time course of that epidemic. And so in that Science paper, very nice diagram, at the beginning of an epidemic, at the uprising phase, there's a lot of people with recent infections shown in the diagram here in red, and there's some who've had infections fairly recently, not so many who've had old infections. And we know with viral shedding, for people who've recently been infected, their viral load is pretty high, and then it comes down over the space of maybe 3 weeks or 4 weeks. Even 3 weeks after first testing positive, many people still test positive by PCR, at least with an assay that's very sensitive, with a threshold that's set at quite a sensitive level. But as an epidemic's coming to an end on the right-hand side, there's relatively more people who've recovered, and there's relatively fewer recent infections. So the balance changes. And that means that towards the end of an epidemic, the viral loads tend to be lower, the CT values tend to be higher, and that shift gives some indication about epidemic growth at the bottom or epidemic decline. So in the Science paper, James Hay and colleagues of his described how testing data could be used to infer what was going on in the population, with an example from a nursing home in Massachusetts. We took that and we applied it to all the data we have in Hong Kong, because for the first 2 years of the pandemic, every case was being isolated, every case was being tested. Once they were detected, they were being tested repeatedly. And so we had a lot of data on CT values. In this particular paper we published in Nature Communications, we looked at the skewness in the CT distribution to show that as the epidemic progressed each time, the third wave on the left, the fourth wave in the middle, as the epidemic progressed, we could have an inference about the RT. And so at the top, the line is the incidence-based RT, just based on the case counts. And in the middle is the CT value. And we see that it's kind of tracking along with that. It's kind of fascinating. And so we can use the CT values to improve our estimation of RT. And there's a lot of description in the paper, but the idea is as time goes on, we take the cases who are newly diagnosed on a daily basis, we look at the distribution of CT values, and we feed that into our real-time model to try and improve our estimate of RT. And it seems to work reasonably well. I think there's more that can be done, but as a starting point, it's kind of interesting. And in Hong Kong, we were doing such a lot of testing, contact tracing, and surveillance and so on, that we have the incidence-based RT to compare with. But I know in many other parts of the world, that's been more of a challenge because testing is not done so much sometimes. And it's been difficult to get a handle on how RT has been changing. So with surveillance platforms now and in the future, community-based surveillance in outpatient clinics and so on, maybe there's an opportunity to use CT values to get more of an insight into how an epidemic's going. One issue we have to be careful about, though, is how exactly data are generated. And that's one of the things we did look at in this paper. If every case is being tested on day 2 of their infection, and there's not much testing of people later in their infection, then the phenomenon will not happen so much. If I just go back, the phenomenon described at the top here applies relatively more to when lots of people are being tested for different reasons, not purely people being tested within a short interval after symptom onset. So in Hong Kong, we did have that because we had lots of people that were picked up by dragnets of contact tracing or testing notices put on their buildings or workplaces and so on, and elderly homes being tested from time to time. But obviously, if there's only symptomatic testing, then that's a little bit different. So in terms of the vaccines and the hesitancy, we have 2 vaccines available in Hong Kong. We have the inactivated vaccine called CoronaVac, produced by the company Sinovac. It's one of the 2 inactivated vaccines used in mainland China, one of the 3 inactivated vaccines used in mainland China, Sinovac's vaccine, and then 2 other vaccines produced by Sinopharm from different parts of the country. So that's a very widely used vaccine around the world. The mRNA vaccine is the Pfizer vaccine. In Hong Kong is marketed by Fosun Pharma, produced by BioNTech in Germany. So we had the mRNA vaccine produced in Germany, imported into Hong Kong, and the CoronaVac vaccine made in China, mainland China, introduced into Hong Kong, imported into Hong Kong. And both of them started to be administered in February and March 2021, initially to older adults and healthcare workers, and then progressively to younger and younger people. And but by the end of 2021, vaccines were available down to age 3. And so those are the 2 vaccines available. In terms of the market share, I'm not sure if I have much information in my slides on that, but it's not too different between the 2. I think there's a little bit more use of the Pfizer vaccine, but maybe 60-40 split, something like that, in terms of the vaccine doses that have been administered across Hong Kong in the past 2 years. So we were tracking with our telephone surveys the intention to receive vaccination, and it was looking reasonable. About 60% of people saying they were interested to get vaccinated before the vaccines rolled out. And obviously that was a time when there was still a lot of uncertainty about how well the vaccines were going to perform, what the schedules might be like, and so on. And as the vaccine program began to be rolled out at the end of February, intention still about 60%, but it dropped, unfortunately, in early March of 2021, linked to reports of side effects in some older adults that were picked up in the media and in social media and talked about a lot. Just a small number of thrombotic related deaths that occurred in people with other underlying medical conditions who were vaccinated. And there was, unfortunately, that some of those people passed away from strokes or heart attacks. And there was a concern about whether it might be linked to vaccination. My colleagues in Hong Kong U School of Pharmacy, Department of Pharmacy, have done a lot of analyses of side effect rates, of side effects of different types after the 2 vaccines that were used. And there's some evidence of a very small increase in the risk of some events, but certainly very clear evidence that the benefits of vaccination far outweigh the risks of vaccination. But I suppose you would say maybe that the risk is not 0, it's a little tiny bit above 0, but still that the benefit far outweighs that. But anyway, there was a lot of concerns raised about the possibility of side effects. So in March 2021, in one of our surveys, we asked people about hesitancy, essentially. The green in the middle here is people who are saying that they're interested to get vaccinated, but they're going to wait and see what happens. Orange is people who are not going to get vaccinated, and blue is people who say they're definitely going to get vaccinated fairly soon if they can. And so we were imagining that hopefully most of the green group would choose to get vaccinated. We also broke this down by age. And so when we look by age, the youngest group at the top of adults, the older people at the bottom of this figure, we see hesitancy was generally, and resistance to vaccination was generally more common in younger people, less common in older people. And I think that was seen in other parts of the world, that the vaccine hesitancy and resistance was a little bit higher in younger people, a little bit lower in older people. Now, that was March of 2021. The vaccine program continued, and by September of 2021, and this is in a period of time when, remember, there were very few infections in the community in Hong Kong. We had this long period, the second half of 2021, without any case in the community, government messaging that zero COVID is working, it's going to continue, there's not going to be large numbers of COVID cases in the community anytime soon. Vaccine coverage got to pretty high level, 60%. The intention was a little bit above that, but the actual uptake was approaching 60% by September, which is not bad compared to many other parts of the world. And this was with the Pfizer vaccine, the BioNTech vaccine, and also the inactivated vaccine with a share to each. But in September 2021, we had an issue with vaccine uptake in older adults in Hong Kong. And so now the color changed a little bit, sorry. The green at the bottom here is people who received at least one dose. Now, most of those went on to get a second dose. There's not many people who stopped at one, but it was only about 30% of older adults above the age of 65 years had received one vaccine dose. And that's a very different picture to what I showed you in March of 2021, when the hesitancy and resistance was higher in younger adults. Now is switched, and the hesitancy is actually the highest among adults in the oldest adults. And if we go to over 80s, the uptake was even lower. We did a qualitative study to try and figure out what were the reasons, and it turns out there were a lot of reasons from a fairly small pool of people interviewed for this qualitative study, a lot of reasons why there was hesitancy in older people. Listed on this slide and in the publication with a lot of details. I highlighted some of them in red. It's that the doctors were not particularly encouraging when older people asked if they should get COVID vaccination. Family members were not particularly supportive. The government was on one hand saying everyone should get vaccinated, but then in the next sentence was saying there won't be any COVID in the community anytime soon because zero COVID's going very well, and the containment measures are holding up. So in that sense, the risk assessment is maybe that there's not much imminent risk of getting COVID, and that was different to the messaging used in Singapore, where the Prime Minister in, I think, the middle of 2021 gave a public address where he was very frank and explained to the public that zero COVID measures in Singapore will not last forever. They're being used to buy time so people can get vaccinated, but sooner or later the measures will have to stop, and then COVID will spread. People will be getting COVID most likely, and it would be safer for them if they got vaccinated before they got COVID. And the vaccine uptake in older people in Singapore was very high, partly from that kind of risk communication, and partly from some of the mandates and the pressure that was used to persuade people to get vaccination. That didn't happen in Hong Kong until later. That pressuring, the mandates and so on. So a lot of issues with hesitancy, unfortunately. My colleagues and I wrote a commentary in BMJ blogs about zero COVID ultimately having to end. We have to plan for a transition away from that, and high vaccine coverage is really important. So this was in August of 2021, recognizing that we can't keep going with zero COVID forever. We have to think about something else, especially when vaccines are available. And also we have in mind this kind of diagram where on the x-axis is the public health impact of COVID that we don't want. On the y-axis is the social and economic disruption that we don't want either from the control measures. And we have to recognize that control measures around the world had a lot of impact on society and on the economy. And so in 2020, the lockdowns around the world, the measures used in Hong Kong made a lot of sense to trade off having less public health impact, but having more social and economic disruption. But that can't go on forever. Once vaccine coverage is higher in older people and vulnerable people, the equation changes, and there's maybe less rationale to continue with a lot of measures. That doesn't mean that the best solution is to drop everything immediately. Unfortunately, that did happen in some parts of the world. But certainly the longer term must be to try to reduce the amount of disruption from public health measures, although recognizing that then the virus will be causing some health impact, unfortunately, among many other health issues facing populations. In early 2022, the dam broke in Hong Kong. We had Delta, we had Omicron BA1, and we had Omicron BA2 in our communities in early 2020, very late 2021, early 2022. That was despite very stringent quarantine that was at 21 days by the end of 2021. I myself did a 21-day quarantine in a hotel room somewhat smaller than the one shown on this screen. And once you're in the room, you can't leave. You can order food to be delivered. I had my computer, I did my work every day, order some food, and you can leave your trash outside the room in the corridor, but that's it. Unfortunately, what we recognize in hindsight is that a number of times the virus was able to spread in quarantine hotels. They're not designed for quarantine. They're not negative pressure isolation rooms that are built in some hospitals. They're just hotels. If you've ever stayed in a hotel where you can smell cigarette smoke from the room next door, that's because there's some airflow coming between the two rooms. And what we found with COVID is on some occasions, maybe when the doors were open at the same time, maybe windows open and change the airflow, virus spread from one room to another. And we just published a paper fairly recently trying to quantify how frequently that happened. It happened quite a number of times. Not every time there was an outbreak as a result, but with Omicron particularly, there were a number of community outbreaks that we know, a number of occasions when the virus spread. And one of those, unfortunately, led to Omicron BA2 spreading in Hong Kong, and we couldn't stop it. So we have Omicron BA1, 2 separate outbreaks linked to aircrew who left their quarantine procedures earlier than they were supposed to. We had Delta, which was a very interesting story relating to hamsters from the Netherlands. And on the right-hand side, you can see that the hamster with laser beam eyes causing an enormous amount of destruction in Hong Kong. But unfortunately, the Hong Kong government had this revenge on hamsters because it ordered a cull of thousands of pet hamsters in Hong Kong in January 2022, a year ago, including many hamsters that had recently been gifted to children as Christmas presents and had to be handed in to the government, to the agriculture department for humane culling. There's a Lancet paper from my colleagues describing the entire set of incidents, but essentially the Delta outbreak started when fortuitously a case was identified of Delta in the community in a pet shop owner with no other known source of getting Delta. The animals were tested and the hamsters were positive. And then there were some other cases linked to that. And it turned out that there was a handful of hamster to human events and quite a number of human to human events. The realization that COVID could find its way into the community in Hong Kong, not only from humans, but maybe this other route that hadn't been thought of before. Omicron BA1 and Delta were both contained successfully by testing, contact tracing, isolation, quarantine, and some social distancing measures at that time. But Omicron BA2 was not contained, unfortunately. The numbers of cases were initially low, but they kept getting larger and larger and larger. And there was a recognition, I would say, by early February that the measures were not stopping transmission, were not containing transmission, and there was a heavy focus on containment. So there's one article from the 8th of February 2022 from the chief executive, the leader of Hong Kong here, quoted saying that zero COVID is still the right thing to do in this wave of Omicron infections, despite it seeming like containment measures are not working. We subsequently looked at the dynamics. The bottom panel here is the exponential rise in infections through February. We had an estimate of a doubling time of about 3 days by early February. And that just kept going and going and going until we estimate maybe half the population were infected. Could have been more than that, but I'll show some data on VE in a moment, a bit later in my talk, to explain why maybe it wasn't more than that, because this epidemic was not contained and we had no prior immunity from infections. Less than 1% of people had had COVID up until this point. And unfortunately, the scenes in Hong Kong were very upsetting. Like in other parts of the world, I'm sure in parts of Canada earlier in the pandemic, we had lots of people waiting outside hospital because there wasn't enough space. Once they got into hospital, they were packed together, and there's not really quite enough resources to look after everybody as ideal as possible. The photo in the bottom right is from one of the local newspapers, taken in a ward where there was not even enough space in the morgue to handle the people who passed away. And so the body bags were left on the wards next to patients who were still struggling to breathe. And it was really quite upsetting at the peak of the Omicron wave in February, the end of February and early March of 2022. And one of the factors which contributed to the heavy impact was even in late February and early March, there was still a lot of emphasis on containment rather than mitigation. So for example, when there were cases in elderly homes, there was a real effort to try to stop transmission by moving all the people to other places and trying to isolate the cases and quarantine their contacts and so on. And healthcare workers, if they tested positive, had to be isolated themselves for a period of time. If their family member was positive as a healthcare worker, they had to quarantine sometimes. That was changed eventually to allow testing to exit quarantine. But the transition to containment, from containment to mitigation, could have been done more quickly. So that wave of Omicron BA2 in early 2022 resulted in about 10,000 deaths in Hong Kong. Remember, we have 7.3 million population. So the per capita mortality rate was more than 1 in 1,000. And it was the highest at that time in 2022 worldwide. And I think in the calendar year of 2022, when all the countries are listed out in terms of their COVID mortality rates per capita, Hong Kong is number 1 on the chart. It's the highest per capita COVID mortality in the world in 2022. And if you look until the end of 2021 here, we were at the other end of the league table. We were one of the best in the world, and we were doing a lot of testing. We were confident that number was a valid estimate, that there were really very, very few deaths. So it was a dramatic turnaround, unfortunately. One of my interests is thinking about severity of infections and how severity changed over time and how we can track severity over time. So in this analysis, it's just preliminary at the moment. We try to split the case fatality risk into 2 components. One is the chance that cases are hospitalized, and one is the chance that the hospitalized cases die. And for the second one, for this bottom, the hospitalization fatality risk, we see over time is typically in the range 10 to 20%. And we have our own definition of hospitalization to allow for more comparability across waves. But in the peak of our Omicron BA2 wave in February and March, it was as high as 40%. It was like 3 times higher, we estimate, because of the pressure on the healthcare system. And that's really a missed opportunity to flatten the curve even more and to protect older people with vaccination, because the vaccine coverage was really not that high in older people. But there's a question, isn't Omicron milder? When we look purely in unvaccinated individuals, we find that Omicron is not actually that much milder than the ancestral strain. Maybe, I mean, it's in the ballpark, maybe it's a slightly bit milder, but it's really not that much milder than the ancestral strain in unvaccinated individuals. We think that apparently Omicron is milder in reality in many parts of the world. That's because of the immunity that's been built up in other parts of the world through infections and also vaccinations. So I'm actually I'm not gonna show the stuff I'd thought about showing on vaccination, because I want to leave a bit of time for questions. I would just highlight that in terms of vaccine effectiveness, both the vaccines we used in Hong Kong were highly effective. We don't have concerns about the inactivated vaccines effectiveness. After 2 doses in older people, effectiveness, it could be higher, but a 3rd dose, which many people had received when they've been vaccinated, that there was a booster program, the 3rd dose brought the effectiveness back up to high levels. This was with an ecological study. It's more difficult to estimate VE now. And I think I'm just gonna whiz over to the current situation in Hong Kong. We've been dealing with COVID for the whole of last year. There's still a lot of cases. Just recently, we had quite a lot of people with COVID in hospital, unfortunately. And so despite having that enormous Omicron BA2 wave, we're still struggling to manage COVID. The measures in Hong Kong were kept in place for the majority of 2022. A lot of social distancing measures, mask mandate is still in place. But just in December, when China relaxed their measures, the Hong Kong government also started to relax the COVID measures that we've had in place. So I'll just finish with some general comments, I suppose, that firstly, a planned exit from zero COVID could have been safer than an unplanned exit. And I think the same would apply to mainland China in December 2022, that more planning, more preparation could have helped. We know now in hindsight that the low vaccine uptake in older adults was an issue that could have been addressed sooner and could have saved many lives if the vaccine uptake had been higher at the time when Omicron BA2 would eventually spread in the community. And then maybe a very general hypothetical point. We've shown that containment of COVID was possible for 2 years. Australia, New Zealand, Singapore had some success in containment. I've been writing guidelines for pandemic preparedness for influenza pandemics. And usually the first paragraph of those guidelines is about how containment is not going to work for long and mitigation would be better. And then there's 100 pages of guidelines about mitigation measures. I'm thinking now that it might be worth spending a little bit more time on containment as at least a more plausible option in the short term for some parts of the world, particularly islands or places that borders can be controlled more easily. But there's some advantages to containment rather than mitigation. Different measures are needed for containment versus mitigation. And it's just something to think about. I certainly wouldn't say that in the next influenza pandemic, everyone should do containment, but I think we can revisit what the plans are for pandemics and think more about the option, at least, of some kind of containment for a short time. And I finished there. Sorry, I didn't have a chance to share some of my work on vaccines, but maybe I can do that another time. And it's the picture here from 2019. Team in Hong Kong now is a little bit larger because of the expansion in the pandemic, but many people have been involved in the projects I presented today, supported by a number of funding bodies, which we greatly appreciate. Thank you very much.
Thank you, Ben. And let me start by saying that you are more than welcome to come back again and again, and given especially that you're also Canadian. So any questions and comments from the audience? I do have a number of questions, but if you have questions, you can raise hand. You can just unmute yourself and ask the question directly. Maybe I can start with first question, Ben, because while waiting for others. Now, it's very interesting observation about how the public health intervention changed the zero intervals. And your picture seems to indicate the public health intervention seems to work to shorten the zero interval. On that hand, although we don't have data from China, mainland China yet, but the zero interval was just very, very, very short for the current situations. The public health intervention is virtually non-existent. So what can we say about this? Really, why?
Yeah, so my team, we've been looking at data on serial intervals over the last 3 years, and it seems like the variants have progressively had shorter and shorter serial intervals. Delta was shorter, now Omicron is shorter, and the latest Omicron subvariants, the ones that are circulating in China, even shorter again. And so that process is something to do with the viral replication, maybe in the upper respiratory tract now, maybe the speed, the efficiency of replication is faster or something. But I don't know to what extent there's been changes during the current epidemic in China. This one on this slide is the early phenomenon with their very stringent containment measures. But as you know, in December, they dropped everything overnight. And so without containment measures, I'm not sure there would be much pressure on the serial interval in that sense. But still, through an epidemic, there's possibly a phase shift. So if anything, we'd expect shorter serial intervals in the early part because of observation biases, and then longer later. And one of the things we need to be very careful about is when we only observe these metrics early in an epidemic, we know they're going to be a little bit shorter. Incubation period will be shorter, serial interval will be shorter, because we're not picking up the longer ones because they haven't happened yet on average. So that's really interesting. There's a question in the box about CT and transmission. So I think this type of analysis with CT values is very well suited to wastewater surveillance, because that's just a dragnet across a community who are served by that water treatment system. It's not symptomatic testing within a day or two of onset. So I think the CT values in wastewater will change. They will. The CT values will go up, the viral loads will come down as an epidemic progresses, and when it's peaked, the viral loads will then on average become lower and lower. One of the things we don't have, I would say, is a reference point. And in this analysis, we had to be careful about the kind of typical CT values from cases. And in our training and testing period, it was the same strain. It was ancestral virus, the Wuhan strain from the beginning of the pandemic. But with Omicron, the CT values on average are different. There's a shift. And so we'd need another source of information on what typical CT values are like, I think, before being able to do this RT. But I think there's a lot of potential in using wastewater surveillance, not only for COVID, but for other respiratory viruses as well, perhaps. And one of the things to derive from that surveillance data stream could be at least a rough inference about the reproductive number. It's useful to know if an epidemic is peaking or if it's peaked, because that's not always clear on the ground. And maybe something like wastewater data would be able to give at least a rough idea of when the RT is going to come below 1. I think that remains to be seen, but I'm sure there's going to be a lot of work on that, given what's happened in the pandemic and the opportunities that people have seen.
Great, thank you, Chris, for your question, and thank you for the answer. Other questions?
I have one question.
Go ahead.
It seemed like the zero COVID policy in Hong Kong and the fact that it was so effective, it was almost a bonus and a detriment, because it led towards increased vaccine hesitancy, or maybe a false sense of security, which is what resulted in the large outbreak at the end.
Yes, I think you're right. And there was a contrast between the policy announcements in Hong Kong compared to the policy announcements in Singapore and also Australia and New Zealand, where in those locations, they explicitly said zero COVID is only a temporary strategy to keep infections at a minimum, to buy time to get vaccines out. Zero COVID won't be the strategy forever. But in Hong Kong, the message was different. The message in Hong Kong throughout 2021 was that zero COVID will be the long-term plan. Even in 2022, you can find announcements in Hong Kong about zero COVID being the ideal and being the rationale for what's happening. And in mainland China, I think at the Party Congress in October, President Xi Jinping made a statement about zero COVID being the long-term plan for mainland China in October of 2022. And it was just in December that there was this rapid change in strategy. But I think there's a difference in concept between containment that's intended to be there forever versus containment that's just used as the best of the options temporarily until there's other better options available. And in hindsight, I mean, I don't think like permanent containment is really going to be sustainable, even if the virus hadn't changed. If we're still dealing with a less transmissible virus with reproductive number 2 or 3, with R0 2 or 3, I think Hong Kong would still not want to be doing containment at this moment in the pandemic when the rest of the world has returned to normal, because of all of the consequences of containment, restricting travel to a trickle, measures in the community that are very disruptive, a lot of other indirect impact on mental health and on the economy as well, which is a lot of cost. And so that, yeah, I think you're right that the success of zero COVID was a major contributor to vaccine hesitancy and the low vaccine uptake in some age groups, particularly older adults.
Ben, I have a final question for you. This is related to, it's relieving to hear the assessment from Hong Kong about the efficacy of the vaccine, including the one used from manufactured from China. Yeah. On the other hand, and given the extremely high infections in mainland China and recently, would that mean the vaccine was done too early, or it waned when they suddenly really lifted? Yes.
Yeah, so I think that's a really good point. In Hong Kong, the data we have here on 2 doses is mostly 2 doses within about 6 to 9 months of the infections. 3 doses is within 3 months. So it's very recent 3rd doses because of the timing of the booster campaign. And we think that did contribute to the protection. I've got another slide I didn't show on infections, just published in Lancet Infectious Diseases, where we estimated that recent 3rd doses provided a low to moderate level of protection against infection. And that's even for the inactivated vaccine that in general we think doesn't do a very good job against infection. A recent dose, maybe it does enough for the immune system that there's at least this short-term protection, maybe for up to 3 months. I don't think it's long lasting. But in mainland China, most people who got vaccinated in 2021. The vaccine uptake a year ago was 85%. It's now 90 something percent, but there wasn't that many 3rd doses given. There wasn't a 4th dose campaign until December. And I think that was a missed opportunity. And what we found, I would say in Hong Kong, is that the booster campaign was perfectly timed in November, December, January of 2021 and then 2022. A lot of booster doses were administered. Admittedly, in older adults, it could have been much higher, but in general, the booster campaign timing was good timing. And for mainland China, if in October they had the plan to transition in December, it would have been a great time to do a nationwide fourth dose campaign and push the uptake up as high as possible. And the images we've seen in mainland China in the last month, I think the impact would have been less of COVID in terms of severe cases and mortality with a well-timed booster campaign.
All right, we have one more question from Sung Muk.
Yeah, hi Ben, thank you for sharing your valuable experiences. I was really intrigued by the decreasing dispersion parameter over time due to the increased cases with the zero transmissions.
Yep.
Now, in that sense, like I'm wondering how we can accurately understand the changes in the super spreading events.
Yep.
Over time.
Well, this may be unique to Hong Kong, where we were doing very effective containment and we got infections all the way down to zero with all this contact tracing. So I would like to know how something like this would look in epidemics that you've had in different parts of Canada, perhaps, or in other parts of the world. I mean, I think it's an open question, in my opinion. As I was saying at some point in my talk, that we often think these parameters are somehow quite stable over time, and that may not be the case for various reasons. Obviously, control measures will make a big difference, and if there's measures in place to prevent super spreading events from occurring, like not allowing large gatherings or even going as far as keeping people at home, that's obviously going to affect K. But then those measures do get relaxed at some point, or people tire of them. So I just hope there's some kind of data that could be used. One of the things we're looking at now is virus sequence data, trying to link together clusters using the sequences and see if that gives any insight into super. Like, for example, if we have sequence data, can we estimate K? That kind of thing. I don't know, because sequences are often quite similar, even with clusters that are not very related. But that's a question that we're thinking about.
Thank you.
Thank you very much again, Dr.